Good evening to those on the East Coast and those in the Midwest, and I guess good afternoon to those on the West Coast. My name is Brian Abrahams, and I am the CEO of the American Friends of Sheba Medical Center. We have a pretty fascinating program for you tonight. When it was first conceived and planned, it was obviously a very different situation in Israel, and this has been very difficult days for those of us who love Israel and care about Israel. Obviously much more so for the people there who have endured over 4,000 rockets fired. And Sheba Medical Center has obviously felt this too. There was a rocket that got through. The Iron Dome system is remarkable, but it's not 100%. And one of the rockets that got through landed at just 1,000 meters from Sheba. But the 10,000 professionals there have not missed a beat. In fact, what they've had to do, there's an underground parking garage there, the hardened underground parking garage that's also wired and set up to do patient care. And so during COVID, it was actually, the parking garage was turned into a COVID ICU unit. And we all celebrated just a couple weeks ago when it was converted back to a parking garage. It was a sign of Israel's success with COVID. And in fact, the Prime Minister had put Sheba Medical Center in charge of Israel's entire national response, which is considered among the best in the world. So that parking garage was converted back to a parking garage. And now it's actually been tragically had to be converted back to an ICU. At first, it was just neonatal. They moved all the infants and premature infants and ICU infants, NICU infants down there. And now they've moved all the oncology patients. And you can imagine, we have photos. You imagine the elderly folks who are being treated inpatient for cancer and now have to gather up all their things and move down to a windowless underground parking garage. But this is what has to happen. Sheba, whatever is happening in Israel, Sheba is at the forefront of it and is the largest medical center, not only in Israel, but in the entire Middle East. They're a key cog in what happens medically in Israel and even for some other countries in the Middle East. So we've got a lot of really interesting material for you tonight. And to introduce our panelists and our program, I would like to turn this over to the fabulous Southern Regional Chair, Dr. Jillian Hotz. Jillian.
Good evening, everyone, and thanks so much for joining us. We're really excited about our presentation this evening. So, of course, due to the time difference, Dr. Eyal Zimlichman, the Sheba Medical Center's Deputy General Director, Chief Medical Officer, and Chief Innovation Officer, has prepared us a video which we'll use to kick off the program. He'll then be joined by two of our top Florida scientists, Dr. Sylvia Donnert, one of my colleagues at the University of Miami, Professor and Lucille P. Markey Chair, Director, Dr. J.T. McDonald Foundation, Biomedical Nanotechnology Institute, and the Department of Biochemistry and Molecular Biology at the Miller School of Medicine, will be joining us as our second speaker. And then we'll top things off with Dr. Summer Decker. She leads the Tampa General Hospital University South Florida Health Division of 3D clinical applications at the hospital, where she provides 3D modeling and 3D printing assistance for Tampa General's most complex surgical cases. She's also an associate professor at USF Health and Tampa General Hospital. I also would like to just add here, with the help of one of our board members, Dr. Debbie Hoffman, in March, Tampa General Hospital and Sheba Medical Center announced a 3-year collaboration. We're excited about the ground sharing commitment to accelerate medical innovation and best practices. This agreement is expected to generate some groundbreaking developments. So we're all excited about how these presentations are going to go tonight. There will be time for Q&A following the remarks. We ask that you submit any questions in the chat feature at the bottom of your screen for Zoom. And I'd just like to thank everybody for being here with us and for your support of Sheba Medical Center. So without any further ado, I think we can start the program.
Good evening. My pleasure to join you this evening, even if it's only virtually and in spirit. Hopefully next time we'll be able to meet in person. But I wanted to share with you the story of innovations coming out of Sheba during COVID-19. I want to start by, of course, thanking everyone that joined us today for the American Friends of Sheba Medical Center webinar, hosted today by the Southern region. And thank our guests from University of Miami and University of South Florida for their ongoing support and commitment to providing the best healthcare possible for their community. My name is Professor Eyal Zimlichman. I'm the Deputy General Director of Sheba Medical Center. I'm also the Chief Medical Officer and the Chief Innovation Officer at Sheba, trying to balance between the problems of day-to-day life and our achievements in health on one hand, working with innovation to try and solve our biggest challenges. And you, of course, know about Sheba Medical Center. I don't need to tell you too much about the size and the big impact that we have in the country of Israel, our footprint in the country and the region and globally as well. But Sheba Medical Center has an innovation program called ARC. ARC stands for Accelerate, Redesign, and Collaborate. Accelerate innovation to redesign healthcare by collaborating with partners. And ARC is focused on 4 principles. The first one is focusing on digital health, understanding that digital health is what's going to make the most transformations in healthcare going into the next decade. Second is open innovation, working together with the industry, with large corporate partners, with startup companies and so on. It's not us against them, but working together to try and have a clear impact on healthcare. Working internationally, finding the best international collaborations to achieve the goal of transformation in health. And finally, building the right innovation infrastructure that will allow us to take innovation to the next level, whether it's physical, like our ARC Center at Sheba, or data infrastructure, as well as funding and regulatory that are critical as well. Now, when we talk about ARC, we're focusing on 6 areas that are the ARC hubs, and you see them here in this photo. This is on day-to-day what we're doing, from big data and artificial intelligence, to virtual reality and augmented reality, to the operating room of the future, telemedicine, of course, rehabilitation, and precision medicine. And this is the whole ARC community, the ARC ecosystem, from our international collaborations to the corporate strategic partners, startup companies, almost 70 of those, and of course the academia here in Israel we're working very closely with. Now, then came COVID-19. You know, ARC was very young, about a year and a half ago. We launched officially ARC after spending about 3 years to build it. And we were first faced with the problem when the first passengers from the Diamond Princess cruise ship returned home to Israel. You all remember the cruise ship off the coast of Japan. There were about 12 Israelis, and Sheba volunteered to accept those Israelis who were exposed to the virus and continue to follow them to make sure that if they do develop the disease, we will be able to treat them. We had to make one critical decision. What about innovation in times of crisis? During the beginning of this pandemic, if you remember, people who were not essential either went on leave or worked from home. What about the innovation personnel? ARC has 60 FTEs working, and we needed to make a decision. It took us a couple of minutes to understand that innovation is not only essential, but it is critical if we're going to be able to successfully come out from this pandemic. And we declared what we called battle mode, the ARC COVID-19 battle mode, signifying one thing, that from now on and for the next 4 months, ARC is going to completely focus and deal with COVID-19, with the challenges and the solutions required. We're going to do nothing else and completely devote ourselves to coming up with solutions for COVID. And I'll tell you what happened during those 4 months. First of all, we had to come up with a new game plan. So we had these new topics, these new areas, these new hubs we were focusing on: data, ventilation solutions, diagnostics, telemedicine, therapeutics, and mobile health. So this became our new game plan, while everything else, as I've said, was put on hold. One of the things that was critical for us is to be able to provide high level of medical care, but in the same time, try and keep minimal physical contact between our teams and the patients to try and prevent transferring of the virus to the patient, to our staff, and staff contracting the disease. We needed to use technology to do that. We were already very advanced in telemedicine before COVID, so we utilized many of the solutions we already had, but instead of treating patients outside of the hospital, we were now focusing on treating patients inside the hospital, while, if possible, of course, try to minimize contact. We needed to be able to communicate with the patient, we needed to be able to monitor the patients, and we needed to be able to provide physical examination to those patients, remember, without being in the same room with them, which was our main challenge. And we came up with this zero-touch telemedicine toolkit, monitoring technology like Early Sense and BioBeat that allowed us to continuously monitor vital signs, and using artificial intelligence solutions to know which patient is about to deteriorate, use physical examination technology like TytoCare and others to allow us to listen to the heart and lungs, look into the throat or the ear of the patient from afar. It could be in a room next to the patient, but it also can be thousands of miles away, and allow us to communicate and manage the patients through our app with a company called Datos. This became our comprehensive toolkit that we later utilized both to treat patients inside the hospital and also outside. We actually erected a tent. This is our teletent, one of the tents we use typically to deploy in times of emergency around the world, whether it's man or nature disasters. And this tent was deployed in Sheba with the clinical teams working from inside to care for patients initially within the hospital, really totally rethinking how to treat patients during these times of emergency. You see here Dr. Gadi Segal, the head of the first Corona unit, who's now listening to the heart and lungs in this photo of a patient who was hospitalized inside our first Corona unit, looking down the throat for that patient and making clinical decisions based on the physical examination and communicating with the patient from afar. We later took the same technology and packaged it into what we call the home kit, which was sent to a patient who needed hospital at home environment. We didn't want to have all patients come in. If they were mild enough, they could be treated at home. And so they received the same technology to be treated at home with protocols that we would follow for those patients in the days they were hospitalized at home. If everything was fine, they were later discharged from home. But if their condition deteriorated, we would bring them into the hospital for a full hospitalization as required. Our ICU was another story. You know, very initial days of COVID, we knew we had to build a larger capacity of ICU beds. So within a matter of 72 hours, we built an ICU unit of 100 beds, 97 beds, inside an underground parking garage, 72 hours. You can see the scheme here. It was really quite a feat to do that. What you see here is our chief of anesthesiology and one of our head nurses driving around in an electrical car within this underground garage to go from patient to patient, which was another piece of innovation. Driving around a ward is not something we typically do every day. We used a lot of technologies within this ICU, but the most critical one was an AI control tower we put together, artificial intelligence control tower. We worked with a company called Clue, and we were able to monitor our patients and predict what's going to happen and react sooner to those predictions, like a patient who's about to deteriorate and might need to be ventilated earlier. We used in-touch telepresence robots to go from patient to patient while our staff stayed in the control room to be able to communicate and manage those patients better. We looked at many solutions for ventilations. As you remember, the initial outbreak of this pandemic, we were concerned that we will not have enough ventilators. And so we worked with some of our partners in the defense ministry, in the Israeli aerospace industry, with Mafat, which is the DARPA, the R&D section of the Army, to come up with these solutions. And by the way, one of the most famous one was a ventilator we've built together with a secret intelligence unit, a unit of engineers. We built a ventilator in a matter of about a month. And you can see the dates here from the time we had an idea proposed to the prototype built, to simulator trial performed, animal models, patents even that we submitted, and productions. With delivery of the ventilators, you see here in the bottom left photo, delivery of those ventilators outside of our critical care Corona unit, and also an agreement for commercializations that were signed. Record time, I have to say that outside of times of emergency, this type of development can take years. And we even went through regulation in the country of Israel. We also built a diagnostic, an ultra-fast COVID-19 diagnostic device that allows us to diagnose patients in a matter of seconds, typically 10 seconds, and at a cost of about $1 per test. Now, it's not as accurate as other solutions, maybe that like PCR that we're using, but for mass testing, like patients or just public coming into a football match or in an airport, this is a perfect solution. You can see here how small the device is, and it needs to be hooked up to a computer to work. And this is now has received, as you see here in this headline, European approval, the CE approval, and we're already starting to sell this technology in Europe and in other parts of the world. And I think it will make a difference now as we're coming out and the prevalence of the disease is dropping. It is better to use a device such as this to regain normality in our day-to-day life. We did a lot of work with data. Right from the get-go, we uploaded the data from COVID patients, of course, completely de-identified, to a cloud, and we had 40 data groups work on the data to come up with insights, typically to try and develop artificial intelligence solutions that will allow us to better treat patients. And this is exactly what we've done. We even had a Corona data challenge in June of 2020, where 15 of the out of the 40 applied to this contest, and the winning group was Intel, as you see here in the photo. And the prize for the first and second prize was actually to implement their technology at Sheba Medical Center, and the technology was indeed implemented to help us treat patients better using analytics driven through big data applications. We had about 12 solutions we've put together in this demo, simulated demo in our simulation center. We call it Health Space 2030, where a simulated patient, an actor, is going through all the phases from diagnosis to initially being treated at home, coming to the hospital, then going on to the ICU when he's ventilated, rehabilitation and discharged home. Luckily enough, there's a good ending to this story. And we've put that as a webinar, a 40-minute webinar, which you could find also online, that describes how we used 12 new technologies to better treat patients. And we used simulation to show to the world what kind of impact this could have. To summarize the 4 months of battle mode, this is what we came up with. 43 invention statements, 13 patents, 15 commercial agreements, 33 service agreements, 274 IRBs, ethical approvals for innovation alone, and even 2 startups that were founded in only 4 months. The acceleration was really immense in terms of the ability to achieve what we typically would achieve in more than a year in a span of only 4 months. And really, to finalize this, we know that times of crisis present opportunities. We know we can work quicker, but also what was very nice here is to see that the structured strategy can go a long way in times of increasing uncertainty. ARC was a very structured approach for innovation. And when COVID came around, we were ready. We launched ARC. We built on top of what we already had, and that was very successful for us. And it's something that we think can be leveraged to other places in the world to use some of the same strategies and same structures that we applied here for ARC. Now, some of these technologies will have a critical impact in the years to come. What we have achieved in telemedicine, and not just Sheba, other places in the world as well, what we have done with telemedicine will pay off for the years to come as medicine is becoming more and more virtual. The solutions that allow us to examine patients from afar would be a key enabler in transforming to virtual care, which is very patient-centered and allows us to provide better care, more efficient care to our patients, and much more patient-centered, of course. What we found with the quick diagnostic device can be applied to almost any virus and any type of bacteria to use this type of device, which is based on photoelectric technology. So these technologies will have an impact in the years to come. But overall, remember, if you have a structured approach to innovation, if you're able to scale innovation very, very quickly and fast pace and accelerate innovation very quickly, like we've done with ARC, then in times of emergency, which could be a pandemic, but can also be man-made, like what we're now facing in Israel. These are other types of emergency, unfortunately. All of that, this would come in very, very handy, regardless of what we face in the future. So I want to end here. I want to thank again the American Friends of Sheba and the Southern region specifically for hosting this webinar. I want to thank our friends in Florida, in University of Miami and University of South Florida. We're working very closely with them on more innovations, more solutions. And I wish that everything in Israel now we'd come down very, very quickly, and we'll be able to have you come and visit. And we would like to see this in person next time. I think we had enough of virtual conferences. It's about time we meet face to face. Thank you very much, and enjoy the rest of this evening.
Hello, and thank you for giving me an opportunity to talk to all of you today and share with you our technology development during the pandemic. And as the prior speaker said, I mean, when there are big challenges, also, we have to think that there are opportunities to help others. And in our case, we also took advantage of a platform that we had been working on for several years to develop a rapid point of care test for COVID-19. And all of you are familiar with COVID-19, so I don't need to linger too much on this slide. You know that COVID-19, the SARS-CoV-2 virus, is a single-stranded RNA virus. So what does this mean? That is made of a ribonucleic acid, which can be found, this particular virus originates in bats, and it looks like from the bats went into an animal, another animal that is called the pangolin, which was the reservoir, and from the pangolin passed on to the human host. So that is the current origin, or what we believe is the origin of the virus that we faced. So what it is important to note, what is important to note is that the pandemic already has caused almost 3.4 million deaths globally, and cases are still rising. There are areas of the country, like for example in Israel, it's very much under control because the vaccination has been tremendous, and the response to the pandemic also has been exemplary. And we all look up to what Israel did during the pandemic and the aftermath of the pandemic with vaccination. But there are countries that they are still in the heat of the pandemic. Luckily, overall, globally, the pandemic is going down, but very much like the flu, this is a virus that is here to stay. And until we can arrive to a place where there is some sort of herd immunity, which it will be difficult to reach, but there is some sort of immunity because of worldwide vaccination, we still have a challenge, and we still have to continue with accurate testing programs, and maybe not so accurate, but some of those that reach that can reach everyone. So in our case, we are molecular biologists and biochemists, and as part of our training, we like to develop tests that are very accurate, and they are at the molecular level. So we can detect very, very small copies of the virus. So how can we do that? Well, all of you know by now what PCR means. PCR is a test that what it does is that when the virus is present, it replicates the RNA from the virus, and you can test it. You can figure out how many copies originally of the virus were present in the patient. And it's extremely sensitive. So you can really detect very low numbers of that virus in the patient. So it can help you with early detection, even in asymptomatic patients. So we were set to try to replicate what PCR does, which PCR is used in a clinical laboratory, a pathology laboratory, and it needs to be heated. The machine has several requirements, and it is time consuming. The samples need to be treated, etc., etc. So we were set to try to do a PCR-like test, but in a point of care situation, meaning anywhere, that can be done anywhere without having to use instruments that are costly and is time consuming to do, without having to treat the sample. Just simply try to do the test and visualize it the same way that a pregnancy test looks. So basically what we do is that we amplify the RNA and convert it into DNA. And then once we have amplified it, then we put it on a paper strip, and very much like the pregnancy test, if you can visualize only one line, that means that the test is negative. If you see two, the test is positive. Within 20 minutes from the beginning to the end, you have an accurate result. So there are no current tests that are molecular tests that are able to do this in the market yet. So let me play a video that will show you how the test works.
Using conventional collection kits. Remove the kit components from the provided pouch, which includes the transfer and collection swabs, the transfer pipette, a test strip, and the 3 tubes containing a running buffer, reaction pellet. Transfer an aliquot of the patient sample into the reaction buffer using the blue-colored transfer swab. This is done by dipping the swab into the patient sample for 2 seconds, and then transferring the swab into the tube containing the reaction buffer, which has a blue cap. Gently mix by stirring with the same swab. Transfer the entirety of the reaction buffer into the reaction tube, which contains the lyophilized kit components. This is accomplished by using the transfer pipettes supplied in the kit. Dissolve and mix the kit components by pipetting up and down 8 to 10 times. Place the reaction tube into a heating block that has been pre-equilibrated to 39 degrees Celsius. Allow the reaction to incubate for 20 minutes. Remove the reaction tube from the heating block. Using the purple-colored transfer swab, transfer an aliquot of the RPA product from the reaction tube onto the sample application area of the provided test strip. Allow the test strip to dry for 1 minute. Place the test strip into the running buffer tube with the purple cap and allow the test strip to run for 5 minutes. Ensure the test strip remains in an upright position. Remove the test strip and interpret the results. The top band is a control line, ensuring the assay has run properly. All valid results must have the top band. The bottom band is the test band, and only positive samples will show this line.
So as you could see, oops, sorry.
Collect test sample.
Sorry. Okay, here. As you could see, the test, it's quite easy to perform. We have even simplified further from the time that the movie was shot. And what I want to show you here, I mean, like, you don't need to think too much about this slide, but what I want to highlight is that symptomatic patients with COVID have more than 1 million copies, billion copies, or higher. Asymptomatic patients, much less, from 10,000 copies. And infected patients can have from single-digit copies to about 10,000. So in reality, what you want to be is to be able to catch any infected patient, whether they are asymptomatic, whether they are at early stages, or whether they are symptomatic. So in our case, with our test, we can detect down to 60 copies of the virus. So 60 copies is nothing compared to the millions that symptomatic patients have. So here is like the utility of this test. So also one thing that we wanted to make sure was that these tests were very specific for COVID-19, and it didn't give false positive results with other viruses that are similar. And we tested it against SARS, MERS, and many others, and it is completely selective for COVID-19. We also made sure that if a patient is taking some sort of medication for coughing or for any kind of allergies or whatever, for example, Zicam, there is no interference from that. And also there is no interference from blood either. In addition, a key component for this type of assays to be able to use them worldwide is that we can make them into test kits that can be transported and stored for long periods of time. And we collaborated with a company in Chile, Merck Biotech, where we send them, we lyophilized our reagents, the kit, and we send it to Chile. And even 13 days after lyophilization, it arrived to Chile and they performed the test and it worked perfectly fine. And from there on, we have been sending it other places too. So we then performed pilot clinical studies in collaboration with the University of Miami Department of Pathology. We did about 87 samples, positive and negative. The test worked beautifully, as you can see, and correlated with the results that they had performed with the PCR in the laboratory, in the Department of Pathology. And it was very accurate. The test is very accurate and worked very well. In addition, we then went and we did a larger clinical study with 125 patient samples. And again, we determined sensitivity, specificity, and accuracy, and we got excellent results as well. The correlation with the PCR, which is the gold standard, was extremely high, 95%. So we're ready to go. This test is working and it's ready to go. And in fact, one of the milestones that we achieved was that we obtained a patent for this test in a record 2 months. And very much like our colleague and friend from Sheba said that the COVID pandemic brought an accelerated discovery and development of the technology. Here is the same. And in fact, we were able to get a patent issued from the USPTO in a record 2 months, when usually it takes 2 to 3 years and more. So we were very excited about that. We have a second patent also filed. We have patents awarded also in Europe and in Asia for the test. And we are collaborating with a biotech company in the Bay Area that are planning to market the technology. Not only that, but they were going to incorporate artificial intelligence for the reading and smartphone technology to make it even more amenable for all types of users, for point of care and eventually home tests. So if I have to just summarize, we really developed a very sensitive, specific, and accurate test that is the equivalent of a PCR, but done without instrumentation. The time that we need to amplify the RNA and the DNA, the time that we need is done at 37 degrees. So in a place like Miami, where it's hot, or in Israel, you could take just like your little reaction tube and place it in the sun, and voila, you're done. It's easy to perform, no equipment needed, fast, can be used in airports or cruises, cruise terminal where the ships are, terminals, in physicians' offices, in community health centers, etc. So we're very excited about this technology because not only will work for COVID-19, but the platform that we have developed can be used for any kind of emerging pathogen that comes along, those being viruses or bacteria. So we're excited, and we're excited to share our technology with you. In that regard, this is my development team that I'm very grateful to them. Without them every day working throughout the pandemic, night and day, this would not have happened. And I'm also very grateful to my entire research group and to all the people that fund our work. Without them, we would not be able to perform our research. And I have to give a shout out to the Ministry of Defense of Israel that fund a different project in our team related to biosensor technology. So with that, thank you very much for your attention, and I'll be very happy to answer questions. And I thank Jillian and the rest of the organizers for giving me the opportunity to be here with you today.
Thank you very much. Our next speaker will be preparing.
Good evening, everybody. My name is Dr. Summer Decker, and I'm presenting from Tampa General Hospital this evening. And I would like to thank Sheba Medical Center for inviting me to present our story of innovation through COVID and one of our inventions. And I think actually after that wonderful presentation that we just have, hopefully we actually will be able to show the reason why that invention that they have is so important. So I'm going to talk to you a little bit today about our 3D printed alternative to the standard of care nasopharyngeal swab that is used in COVID-19 testing. So our team, I wish I could say we had a team as large as that last one, but we actually have a small team here at USF Health and Tampa General Hospital. We are the division of 3D clinical applications. So our day job is really to work within radiology and create 3D models and 3D prints for the really complicated surgical cases that happen at the hospital. So it is myself, I'm the director, Dr. Todd Hazelton, our medical director, and Dr. Jonathan Ford, our technical director. We also use a lot of medical students and residents, as well as fellows as part of our research and clinical practice. So to tell you a little bit of our story about how we worked with COVID, as this kicked off back in March, really here in the state of Florida, we saw that the World Health Organization designated COVID as a global pandemic back on March 11th. And we actually started hearing some really early rumblings at USF where we see some of our administration letting us know, if you're sick, stay home, something's coming, we're hearing some rumblings about this. And interesting enough, the first presentation mentioned the Diamond Princess, and we had actually helped get some of the passengers off the Diamond Princess, which is our first exposure with COVID there. So we started hearing these rumblings of this, and we were still actively doing our clinical work at the hospital. And on March 16th, we actually received a request from the trauma team. We had a patient come in who had been in a motor vehicle accident, and they needed a 3D print for facial reconstruction for a trauma repair. And so knowing that things were about to slow down and stop for our hospital, and elective cases would be slowed down and eventually stopped, we went ahead and did this trauma case. Our dean, Dr. Lockwood, sent out an email really asking about whether or not people would want to work remotely and whether or not we could transition pretty quickly. So we all started preparing to go home. And at the same time, we're hearing from surgeons who said, hey, we still need this print. We know things are up in the air, but we really need to work quickly on this case. So we actually did print this surgery here, this surgical case. But the morning that we handed off around 5 a.m. into the OR, that case for surgery, we received an email from the dean of the medical school letting us know that the hospital was in a bit of a crisis with PPE shortages. We had shortages of face masks and face shields, gloves, and all the standard PPE that we would come very quickly to know that there were nationwide shortages of. But one of the things on the list actually caught my attention, which was the nasopharyngeal swab for COVID testing. And the reason that caught my attention was it was going to be a diagnostic tool. It is the diagnostic tool, the standard of care for being able to determine if the patient has COVID. So with a shortage of a swab, you have a shortage of test kits. And for those of you who are not familiar with the test kit, there are three key components. One is the test tube that contains the viral transport media. The other is the nasopharyngeal swab itself. The swab has got a polyester flocking tip on it, and you can't really use the standard cotton swab, the wooden and cotton, because it actually interferes in the PCR test and with the viral testing. The problem with this swab, though, the nasopharyngeal swab, was that the main producers were actually in Italy and in China. And at this point, both of those countries had shut down. Now, the US military actually flew to Italy and tried to get as many out as they could, and which they were successful, but we were not seeing them at the hospitals. So the entire global supply chain had been disrupted, and that directly impacted the US's ability to even test for COVID. So in the news, you were seeing, why can't we keep up? Why can't we test? This is part of that reason, because we didn't have the components of the test kits for it. So as I mentioned, we get this email and we're sitting there and we think about it and we think, we actually hand off surgical grade material every single day to be operated on and used with patients. We could actually create a replica of that nasopharyngeal swab using 3D printing of the same material. And why it was important was because we needed stuff quickly. We needed to be able to create it in bulk. And there were a lot of different components and different aspects of this we had to think about. So myself and Dr. Ford ran literally from the OR across the street that same March 17th, and we started looking at what we might be able to do with a 3D printed swab. Now, we started this, as I mentioned, within our division of USF Radiology, but we also had colleagues up at Northwell Health in New York City. And those of you familiar with Northwell Health, that is the largest medical center in New York State and in New York City, and they were completely out of test kits. And as colleagues in a 3D world where we work, we knew that, and they had asked for any help that anyone heard. So we immediately reached out to them and said, do you want to work together on this? And we did. And so that is how we partnered with Northwell Health on this collaboration. So when looking at the nasopharyngeal swab, how we knew that there were going to be very specific requirements for it. So one of the things we knew, of course, it must be patient safe. It has to be sterilizable. It must be as comfortable as possible. No, it's a nasopharyngeal swab. It's not going to be that comfortable. We've heard all of the crazy names that patients have for them, like the brain tickler and all that kind of stuff. I always tell people we didn't invent where it goes, we invented the swab. It must be able to grab a mucus sample, an epithelial sample, to be able to conduct the test. It had to be clinically viable. It had to be scalable because we needed to be able to do thousands upon thousands quickly. And it had to be cost effective. It couldn't cost way more than what the traditional test kit was. Otherwise, we would be bankrupting our hospitals. So we actually sat as a team, and on that day, on March 17th, we actually came up with several ideas for the potential of the design. We came up with about 12 different tip and stem iterations, and we ran across the street to our infectious disease team and handed over everything that we had to them within one day. And they actually started testing them on themselves. We tested them on ourselves. And within a day and a half, we had a finalized design. And by that Friday, we actually went to bench lab testing. And here you get an example of some of us testing these swabs on ourselves. And you can actually see where the nasopharyngeal region is and where this swab actually has to go. Now, the printer we used, we did it was very much selected on purpose, because in 3D printing, these are not your hobbyist type printers. These are medical grade printers. And so we knew that when I was walking across the street, my first thought was, this is going to be a medical device. This is going to have to be done according to the FDA by a hospital or a licensed medical device company, which means that we're going to have to get FDA clearance or at least approval from them to be able to do this. Now, knowing our field like we do, we have the software that is FDA cleared, we had the printers that were FDA cleared, and we had the surgical grade materials that have been FDA cleared. So my logic was, if we use all of that, then we can jump to the end and say, does it work? And that's where we started with the bench lab trial. We knew all of it up until that point would clear the FDA. So we actually selected specifically a Formlabs printer. It's actually a little desktop type printer. And the reason we do that, some of the printers that we use in medicine are $500,000 or more. And we knew that we couldn't use a printer like that, even though it was FDA cleared, because not many people would have access to that. But this printer that we're talking about is a desktop printer that is in most hospitals right now. A lot of dental offices, even veterinarian offices have some of these printers. We knew, as I mentioned, that surgical grade material had already been cleared for clinical and dental use. We knew we could sterilize them because we do that all the time. And like I said, we knew that they were out there across the country, so that if we came up with something, we could release it immediately and really harness all of those printers across the globe, really, to be able to address this concern. So we conducted a successful bench lab trial here with our team in infectious disease and the virology team. And what was interesting, we found from that bench lab trial, this is on March 20th, we actually found that the 3D printed swab, not only did it retain a respiratory virus, we could detect it on there. We tested it for several days to make sure that it could hold it for multiple days, knowing that test kits would be held likely when they go to labs. We also tested the material to make sure that it didn't leach out and ruin anything in the test. But what was really interesting was that we found that it actually was outperforming the standard of care swab. While they were doing the bench lab test, myself and our infectious disease director wrote up a clinical trial. We knew that it would need to be properly clinical trialed in as many hospitals as possible. So to be able to increase the number of hospitals, include as many sites as possible, we actually put it up into a national IRB so that any hospital in the country could actually join us immediately. And many hospitals did join us. And our first join, of course, was Northwell, but also Thomas Jefferson University and Thomas Jefferson Medical Center. And so we were able to work together, these three institutions, to come up with some of the earliest results in the nation. It was one of the first IRBs at our hospital. And this was one of the first device that came out for COVID in the country. And looking at this, in this clinical trial that we did, we had a direct head-to-head comparison of the same patient using alternative nostrils. So we would put the synthetic swab or the standard of care swab in one nostril and the 3D printed swab in the other. And overall, the results, what we found was that statistically, the 3D printed swab was as good as the synthetic standard, in many cases better. And so there was a rush from all of these hospital review boards to accept the 3D printed swab as the standard of care swab. Our hospital did it, Northwell did it, and all of the hospitals on our clinical trial were able to do it. So what did that mean? We had a job to do. We knew that we had to create a whole lot of swabs quickly. And so by just changing the way we were printing actually on the printer itself, we were able to create about 324 to 380 per batch. And at a print time of 11 to 16 hours, that meant that we could do thousands upon thousands. And I will tell you, myself and my colleagues, we actually had cots at our hospital, and we would sleep in shifts because we were working 24 hours a day. It was over 200 days before we got a weekend or a day off. And so we also realized that using this material, that we can make them at about 25 cents a piece. We were being charged about $1 a piece for the standard swab. And as I mentioned, these were across the country already. So what we did was we worked with our colleagues in the Department of Infectious Disease and their labs. We would print the swabs, we would clean the swabs, and then we would hand them over to them for sterilization. And each swab was individually inspected, wrapped, and everything before autoclaving. And then they were bundled with the rest of the components and distributed to all of USF Health and Tampa General's affiliate hospitals, including Moffitt Cancer Center, the two large Veterans Administration hospitals here. And to date, our team alone printed over 100,000 test kits for our local hospitals. Now, it was interesting because we were doing this to address our local need, but we also saw what was going on in the rest of the country and the rest of the world. And I remember going to my chairman and telling him, we plan on giving this away. It's the right thing to do. So we actually did file that first week in March 20th. We filed a provisional patent on the idea, and we posted the files with our institution's blessing to a box folder so that any hospital or medical center that needed help could get it for free. We met weekly and sometimes multiple times a week with the directors of the FDA, and we partnered with the company that made the printer itself so that they could actually open up a print farm and start printing swabs to all of the groups that we were not legally allowed to print for. We were actually not allowed to print for anyone beyond our institution and affiliates. And so by doing so, we were able to help people all over the country and all over the world. We actually have agreements right now with the Navy and the Army, and both institutions use ours. And in fact, one of, I think, our coolest collaborations came from the nuclear subgroup up in Maine. They had these printers on their subs, and they were actually able to send them the files so that they could do testing underwater if need be. So we have partnerships right now with the military. Now, there was a media leak actually overnight, and suddenly we were all over the news. And I remember waking up to over 4,000 emails in one day, which was a little terrifying for someone who sits in the dark for a living and looks at medical images. But what we had to do was we had to make sure that we could get it out there, but we also had to do our day jobs. And these were some of the trauma cases still coming in during our COVID adventure. The impact that this swab had on the state of Florida, we were able to provide swabs to the USF Health, Tampa General Hospital, Moffitt, James Haley, and Bay County's VAs. But we also worked across the state to make sure that our rival hospitals in normal times became our friends, and hospitals like Bay Care Hospitals, Nemours Hospital, University of Florida, and Shands Jacksonville, Florida International, and many other state medical schools and hospitals. We helped each of them. This is actually us here handing off swabs. The global impact was that we've been told at the last count that the US VA system actually increased 25% of their 170 hospitals were actually using our swab. That number supposedly has increased, but I have not been given the exact percentage yet. The majority of the hospitals were actually printing them on their own. Some were working with groups like us to actually get their swabs from printing groups at hospitals. This single initiative actually doubled 3D printing in VA hospitals across the US. A number of states used our swab, including the state of New York, Massachusetts, Kansas, Oklahoma, Ohio, Minnesota. I know Ohio alone has over 1 million of our test swab. And over 60 hospitals and hospital systems, including the Mayo Clinic, Brigham and Women's, LSU, all used our nasal swab or participated in our clinical trial. They are currently used in actually 56 countries. And all of this work was published in the top journals for the infectious disease as under the category major paper. One of the things that was an absolute shock to us was that we started getting recognized for the work that we did. We were actually nominated for and won the COVID-19 Heroes of Tampa Bay Award. We were actually nominated by the construction crews in the building who saw us working there and living in the building and working day and night. And they wrote to the mayor of Tampa and said, there's this little team in a corner of a building that is making the test kits to help save Tampa Bay. We also won a 3D printing international impact award for having the most impact on society using the technology of 3D printing for any industry. And I was proud to accept this with my two colleagues, Dr. Jonathan Ford and Todd Goldstein. And actually last week, we found out we are the finalists right now for the Fast Company World Changing Ideas 2020 Award. We are the finalists for the pandemic response category, which was a huge honor for us. Now, this again, I'm someone who sits in the dark and plays with computers, but suddenly we were all over the world's news. We were on the front page of Wall Street Journal and Forbes. I did over 50 interviews, national and international. And my residents were seeing us in foreign countries. It was amazing, Japan, and even the front page of the paper in India. But what this showed was that through all of this collaboration, we were able to work internationally to have over 70 million of our USF Health designed swabs around the world. And that has directly impacted the world's response to COVID. So the big lesson that we learned from this, not only just the power of innovation, is the power of the team. Because the most positive outcome that we really had was the ability to work together, people that were not even in the same fields, working together, taking down all of those silos. We established quickly teams, and everyone contributed. Every diverse member contributed to this group. And we were able to accomplish really the unimaginable, a 3D printed novel device, a COVID-19 nasopharyngeal swab translated from conception to design, bench to bedside in less than 3 weeks. And what was really interesting for us is these are our friends here. These are the surgeons that actually we did their cases for, and they got sent home. They couldn't operate anymore. So they were sent home. They actually came to help us. And so that was some of the team that we had. Now, our team had always worked on helping the surgeons. And what we've been able to show is working together, we can actually come up with really cost-efficient clinical implementations of medical devices that can help millions of patients, really, just by working together in that innovative way of thinking. This is our amazing 3D printed nasal swab team, including the team at USF with internal medicine and infectious disease. We also have our Northwell Health and our Jefferson Health team. And if you have any questions about our efforts on this is our contact information. Again, thank you for letting me present today.
Thank you very much. I want to thank both of you for this is really amazing. It's very humbling to be the dumbest person on the panel. But that's remarkable work that both of you did in your teams, and it really shows. That's one of the, I guess we're the hour's late, so we don't have time for a lot of questions, but one of the questions we've gotten here is, and I'd like both of you, if you could just to briefly touch on it, part of Israel's innovation of culture is the sense of urgency they have in their society always. How are you in the future? Have you had conversations about how you'll capture the sense of urgency that you had that allowed these remarkable accomplishments? How do you do this in the future when there's not a pandemic? Why don't we start with you, Dr. Becker? Oh, or either one of you, whoever wants to take it. Sure,
I'll take that. One of the things that I thought really this illustrated was, a lot of people were surprised. I remember hearing, so radiology's still here. Why are you guys still here? But we found, like, by using the technology that we had, being able to rethink it differently, we could move quickly. And that's one of the things that I think this really illustrated for us, is that looking around at what you have and repurposing what you have really made us be able to move a lot faster. And I've talked to a lot of groups, and they had to go out and come up with designs, go order things, but really looking at the resources you have within your own facility, that helped us move faster. And because we were able to do it all internal, and we actually funded it internally as well.
Great. Dr. Downer?
Yeah, so in our cases, we develop technologies in my lab. We are bio-nanotechnologists, and so we develop enabling technologies. And we already had developed a platform that was able to be used when we had the Zika outbreak in South Florida, and also for other viruses like HPV, that is the cause of cervical cancer. So we have platforms. We don't think small. Whenever we develop technologies, we think, okay, we're going to develop something that will be able to be applicable for other types of problems or challenges that come along. And, I understand the sense of urgency very well. As I said, I work with the Department of Defense of Israel. I have worked for many years now developing technologies. So, I'm with them. That's the way we function in our group. So it's very important to have this sense of wanting to do something, not in the long future, but now, but planning for the future as well.
Sure. We got a question for Dr. Zamachman, which I will attempt to take for him. Can you give me an example of something that's emerged from the ARC that is available now for use here in America? There actually was it was briefly on the screen and he touched on it, but there's a device called TytoCare. You know, one of the things that's changed obviously with the pandemic is a more acceptance of telehealth. And they developed a device called TytoCare. You can buy it online or at Best Buy, actually. I'm not shilling for the company. I'm just giving you an example. And it has a few different things in it. One for looking in the ear. I'm going to get the words auto. Anyway, I don't know what doctors are on. I don't want to use the wrong terms. But the device for looking in the ear, the device for looking in the throat. I think it has a stethoscope. And you basically, it transmits the data either to your own pediatrician or doctor if they'll accept it, or they've partnered with pediatricians and doctors around the country. So I don't know, when I had young kids, we were in the pediatrician's office every week with sore throats and ear infections. And this allows you, and then you're sitting in the waiting room where you're getting sick from the other sick kids. This allows you to transmit data and have the doctors, without you leaving your house, be able to possibly diagnose an ear infection, a strep throat or whatever. Or not strep, but the throat infection. And that came out, and that's something you could buy today at Best Buy. The hour's getting late, and there's a lot more questions, but I'm so grateful to both Dr. Decker, Dr. Downer, what you've done, to Jillian Holtz, for all of you who have sat through this. And I would ask you to consider supporting the work. One of the things the pandemic has taught us is just how connected. When I was looking, I believe it was Dr. Downer showing the bat and the pangolin. I didn't know what a pangolin was before the pandemic. And I'm thinking at one point, sometime in the last year or two, there was some pangolin, this lizard thing walking, that was about to devastate humanity. And it shows how connected we all are. And what the teams here did to create things that they then shared, how connected the solutions can be. And Sheba too is part of that. So in the chat, there's a link at friendsofsheba.org. You can go there, or you can go in the chat and you can become part of this. Certainly, I'm sure both hospitals have ways that you can support their work. And I know, since we're Sheba, that Sheba certainly is looking for the support. That's what we exist for. And so these problems come at us interconnected, but the solutions also come at us interconnected. So again, thank you to all panelists for your amazing and brilliant work. I'm still trying to absorb it all. And thank you, Dr. Holtz, and thank you for everyone who joined us, and have a very safe and healthy evening.